I'll start the second talk. So I'll be talking about PET-CT and lymphoma and giving an update. My name's Dennis Gradinscak. I'm from North Shore Hospital and I'm a radiologist and nuclear medicine specialist, staff specialist at the hospital. In this imaging update, I'll give a bit of a background on PET in lymphoma and also touch on some of the recommendations that were recently published in the JCO based on an ICML conference and a meeting of imaging experts on lymphoma. So as a background, most lymphomas are FDG avid, and the most common histologic subtypes, Hodgkin's lymphoma, diffuse large B-cell, and follicular lymphoma are always avid at presentation. Most indolent lymphomas show variable FDG avidity, and there are a few lymphomas that are non-avid, such as CLL. This table looks at FDG avidity according to WHO classification of the different lymphomas, and you can see in this table that the majority of lymphomas do show FDG uptake on PET, particularly the high-grade lymphomas. As we go down the table into the more of the indolent lymphomas, we see more variable uptake. The uptake of FDG in lymphoma is on the basis of two mechanisms. One is the tumour cells themselves taking up the FDG, but the other is also the surrounding microenvironment of activated inflammatory cells. If we look at the example of diffuse large B-cell lymphoma, 90% of the tumour mass is made up of tumour cells, and the FDG uptake is mainly because of the tumour component in this histologic subtype. And we sometimes see variable intensity uptake at different sites of disease in these patients, and it's thought related to the different clones showing different degrees of differentiation. The other end of the spectrum is Hodgkin's disease, in which only 1% of the mass is made up of tumour cells, and most of the uptake relates to the surrounding microenvironment of the reactive cells, and that explains the very high uptake and the very high metabolic activity observed in Hodgkin's disease. The differences in the nature of FDG uptake also explain the differences in the response kinetics after treatment. With Hodgkin's disease, we see very rapid resolution of uptake, and that relates to the activated inflammatory cells being switched off by the treatment. With diffuse large B-cell lymphoma, we see that as slower to respond, and that relates to the different clones of tumour cells showing different levels of chemosensitivity. As an aside, looking at the role of PET-CT or PET, PET as an imaging modality is relatively new. We've only seen it really take off in oncology imaging in the last 15 years or so. In Australia, we've seen limited MBS approval only in the last 5 years or so. Literature has been rapidly evolving, and also the technology has been rapidly evolving. So we've gone from PET to PET-CT to PET-MR in the space of just over a decade. Because of this rapid evolution, I think standardisation of the way we acquire our scans and also the way we report our scans is really important. And it's essential for strengthening the evidence base we have in future trials and also in the way we practice our trade and make sure that the way we report our scans in clinics is useful. Regarding standardising lymphoma reporting, it's gone through several evolutions. Many experts have gotten together and come up with criteria. Back in '99, we saw an international working group come up with criteria which was mostly based on CT criteria. In 2007, we saw the International Harmonisation Project recognise the role of PET-CT in lymphoma reporting and standardising of imaging protocols. In 2009, we saw an important development, the DeVille criteria, a 5-point scale of the way we report uptake in PET, looking at it as a spectrum of uptake, not just as a binary, positive versus negative. And the 5-point scale is a more reproducible, user-friendly way of reporting PET and defining response. And then we went on to the most current iteration of consensus guidelines, and this was out of that 2013 ICML meeting, and was published late last year in JCO. And it looks at the role of imaging in staging and response assessment of lymphoma. And the subsequent slides, I'll show some key points with some imaging examples to discuss the findings of this consensus. The guidelines look at the role of PET in staging, interim PET, and also end of treatment PET, and also the way we should interpret PET and report it. So point one, the role of PET-CT in staging. PET-CT is the imaging gold standard for staging of FDG-avid lymphomas. We see PET-CT is more accurate than CT for staging in Hodgkin's lymphoma and aggressive non-Hodgkin's lymphomas. It's because of increased sensitivity, particularly for extranodal disease, and upstaging occurs more often than downstaging. We see approximately 10% of Hodgkin's disease patients upstaged from stage 1 or 2 to 3 to 4, and management change after upstaging is more common in follicular lymphoma than other subtypes. This table summarises some of the articles looking at PET-CT versus CT alone for staging. And if you look at the two columns that are highlighted with the circle, the upstaging column and the management change column, we see significant changes with the application of PET-CT, as was mentioned with staging. It's really improved the accuracy of staging, and has also led to changes of management because of that. PET-CT may be used to select the best site to biopsy. We know that with FDG uptake, it is higher in aggressive lymphomas versus indolent lymphomas, and PET-directed biopsy of the most avid disease in a patient is most likely to yield the highest grade histology in that patient, and can also pick up transformation in patients with indolent lymphoma, such as follicular lymphoma. Various SUV cutoffs have been suggested for differentiating high grade versus low grade. The study out of Memorial Sloan Kettering suggested an SUV max cutoff of 10, but there have been other studies that have looked at the same differentiation, and they've come up with different cutoffs. So the literature is not conclusive, and at the moment, the use of SUV alone in staging to define high grade versus low grade is not recommended, but in terms of using it to pick the best site to biopsy, it is a useful tool. The use of CT for staging, contrast-enhanced CT, when used at staging or restaging, should ideally occur at the same time as the PET-CT and preferably as a single visit. The baseline findings on that CT will determine whether or not contrast is useful and whether it should be used in subsequent interim or end-of-treatment PET scans. Staging of FDG-avid lymphomas, when we interpret them, it's recommended that we use a visual assessment with PET-CT images scaled to a fixed SUV display. So that's the PET images on the top right-hand corner are scaled to a fixed SUV scale. I use 0 to 6. Some departments use 0 to 10. But the key thing is to make sure that you always look at your PET scans the same way so that you get your eye in and get used to looking at them in a standardized fashion, and also using a fixed color table. So those are the fused images in the bottom left-hand corner, having the same color table used each time so that you get used to looking at the scans in a standardized way. It's a visual assessment, so it's not required that you quote SUVs, and it's more of a qualitative analysis. PET can be more sensitive than bone marrow biopsy, and this is something that's coming up more recently, in that focal bone uptake, particularly in Hodgkin's lymphoma and aggressive non-Hodgkin's lymphoma, is very sensitive for bone marrow involvement and can obviate the need for biopsy in some cases. If we look at the example of Hodgkin's lymphoma in one study, 18% of patients had focal skeletal lesions on PET-CT, but only 6% of those had positive bone marrow biopsies, or with advanced disease on PET-CT. With early Hodgkin's disease, we rarely see bone marrow involvement in the absence of PET lesions. So in that context, the bone marrow aspirate or biopsy is no longer required. If we look at diffuse large B-cell lymphoma, PET-CT is also reported as more sensitive than biopsy, but it has been reported to miss low volume diffuse involvement of 10 to 20% of the marrow. Patients with early or clinically early stage disease rarely have bone marrow involvement unless there's some findings on PET. And a study by Khan et al. Showed 27% of their patients that were found to have bone marrow involvement, 94% were detected on PET, as compared to only 40% on bone marrow biopsy. For all other lymphoma histologies, the data is insufficient to change standard practice, so bone marrow biopsy is still recommended for those histologies. If we talk about diffuse bone marrow involvement at staging prior to treatment, we can see that in Hodgkin's disease as a benign reactive process. If we see it in the non-Hodgkin's lymphoma context, it's more likely to represent malignancy, but it's usually more patchy and heterogeneous in uptake in the non-Hodgkin's groups. Looking at CNS lymphoma, MRI is the recommended modality. Whilst on PET we know that CNS lymphoma is very avid, the problem with PET is within the brain there's very high background activity, and small lesions and leptomeningeal spread of lymphoma can be missed, so MRI with contrast enhancement is the gold standard for CNS lymphoma staging. Moving on to PET response, I mentioned the DeVille criteria, and what that is, it's a 5-point scale, and the 5-point scale is recommended now for reporting of all PET CT, both for staging, interim and end of treatment PET. And that's a shift that we've seen compared to previous recommendations based on the IHP. So the 5-point scale scores the most intense uptake in a site of initial disease as follows. Number 1 being no uptake, number 2 being uptake less than mediastinum, 3 between mediastinum and liver, and 4 uptake more than liver. Initially that was termed as moderate uptake. 5 being uptake markedly higher than liver and or new lesions, and X designating new areas of uptake unlikely related. And it's been shown in several studies in Hodgkin's lymphoma, diffuse large B-cell and follicular lymphoma that you get good inter-observer agreement using this technique of reporting. So what do these scores mean? Well, scores 1 and 2 on an interim or end of treatment PET scan represent a complete metabolic response. So this image shows a lesion at the right of the trachea, and there's very little to no uptake in that site. So that would be considered a complete metabolic response if this was a follow-up scan of a site of initial disease. Scores 3 also probably represent complete metabolic response in patients receiving standard treatment. And that final proviso, I think, refers to patients that are receiving standard clinical treatment, not those in de-escalation protocol trials where they're looking at potentially reducing the amount of chemotherapy they're receiving. In that context, you might want to shift towards a more stringent definition of complete response, such as a 1 or 2. A score of 4 or 5 with reduced uptake from baseline in an interim scan likely represents a partial metabolic response. If you see it at the end of treatment, it represents residual metabolic disease, and these are the terms, or the terminology that's recommended for the way we report it. And an important change in the definitions or the revision of the DeVille criteria for stages 4 and 5, they were a little bit vague in the past because they were termed moderate and marked. Now there's much more specific definitions of what a score 4 and score 5 means, and we're using SUV max to define that. And the way we do it is we take an SUV max over a large region of the normal liver and use that as our cutoff to define a score of 4. If the SUV max in a lesion, such as this one, which is looking at a mass in the mediastinum, which has gone from DeVille 5, an SUV of about 23 or 27, down to an SUV of 5, which is still above liver SUV max of 3.5. A score of 5 means uptake that's 2 to 3 times the uptake of an SUV max of the liver. And so the image on the left would be an example of a score 5, and the image in the middle would be a score 4. An increase of FDG uptake to a score of 5 or score 5 with no change during treatment or after treatment, or any new lesions constitutes a treatment failure and or progression. There are exceptions to the 5-point scale, and these are lesions which occur in areas of high background physiologic uptake. So we're talking about marrow, spleen, and Waldeye's ring. Particularly the marrow and the spleen can show quite high physiologic activity on the interim scans during treatment or post-GCSF. So if a lesion is known to be present in those organs at the time of staging, and on a subsequent scan, we're not sure, is there uptake there, is there not uptake? The way to define whether or not there's a response, a complete response versus not a complete response, is to say whether or not the uptake is less than the background. If it's less than background in that organ, it's considered a complete response or metabolic response, even if it's still greater than the liver. If we look at the role of interim PET, PET-CT is superior to CT alone to assess early response, and this is well established, and that's because of the presence of the residual mass or lymphadenopathy. It's quite common to see that on an interim scan in very early imaging. If we were to look at the CT top row, you'd see a mass at staging on the left showing some reduction in size. You don't know, does that mean it's a partial response, or is this a complete response unconfirmed? Is this just a residual, a necrotic mass that we're left with? We don't know. So with the PET scan, you get to assess the metabolic activity, and you can make that distinction much clearer. In this case, you've got a complete metabolic response. At this stage, it's not recommended to change treatment solely based on interim PET-CT results unless you see clear evidence of progression. So as was mentioned, the trials are still underway to decide whether or not response-adapted or PET response-adapted therapies should be applied to clinical practice. A brief note on scan timing. We often see non-specific FDG uptake during treatment, which is presumed related to treatment-related inflammation. And so if we're going to perform an interim scan, it's recommended that we should wait as long after the previous cycle as possible. And ideally, that's in the 11 to 13-day period for a 14-day cycle protocol. And at the end of treatment, it's recommended to do it at least 3 weeks post-chemotherapy or up to 3 months post-radiotherapy. The role of PET at the end of treatment. Well, PET-CT is the standard of care for remission assessment in FDG-avid lymphoma. But in the presence of a residual metabolically active tissue or mass where salvage treatment is being considered, biopsy is still recommended. And that's because we occasionally get false positives, particularly in conditions such as diffuse large B-cell lymphoma, because you can get ongoing inflammation in necrotic residual masses. So to summarise, almost all lymphomas are to some degree FDG-avid, and now PET-CT is recognised as the gold standard in staging and also response assessment for the FDG-avid lymphomas. And PET interpretation is now standardised. We're becoming more reproducible in the way we report it, and we are constantly refining the technique. And that's the end.
Thanks very much, Dennis. We'd clearly be lost without this lymphoma, and I guess the next trick is how we bring it in with some other diseases like myeloma, where we'll have the same role if it goes. Have we got any questions, comments from the floor? Certainly essential to us to have access to the guys down in Nuclear Med for our testing. I'm sure we're one of your better customers.
Would you like to comment on the role of full-dose contrast-enhanced CT with the PET?
Well, it's very difficult for us in our context to be doing contrast-enhanced CT combined with PET. I know that the recommendations are suggesting it. It's a bit easier in a different climate. Look, my interest, which I've found in my readings and also in some of the recommendations, is a suggestion that we should look at different ways of quantitative analysis of PET, in particular looking at total your metabolic tumour volumes and TLGs, and that's something I'd like to look at with our diffuse large B-cell lymphomas.
I just looked at that. I think by putting that out in the guidelines, I think we can all accept that so many patients already, the real world situation is so many patients already get a full dose contrast enhanced CT before they have their diagnosis made and then go and have their PET. So I would encourage people not to be going racing to get full dose contrast enhanced CT. And also, as you know, but the rest of the audience might not know, at the end of treatment, we really don't want to be doing full dose contrast enhanced CT because the effects of that on the glucose uptake of those reference organs, the liver and the mediastinum. As for the total metabolic tumour volume, I think that's going to be a really exciting field.
Yeah.
It's demonstrated to be prognostic in diffuse large B-cell.
At Lugano, it was demonstrated to be prognostic in a very heterogeneous population, but quite a large population, French population with peripheral T-cell lymphoma, and we're currently looking at it in follicular lymphoma to expand on Michelle's.
And it looks like it's going to be potentially better than looking at tumour bulk as a prognostic factor. So I think that's where PET can really add to the body of.
But I don't know that TLG is going to add extra.
No, more the metabolic tumour volume. Yep.
That was a great summary. I'm interested to learn how you and maybe your clinician colleagues are dealing with the concept of upstaging, particularly in Hodgkin lymphoma, where the treatments are substantially different. You're getting pressure on to be definitive about interpreting a full contrast enhanced CT together with PET in order to try and determine whether you can find that on a CT alone. Since all the trials, as you know, were done on the strength of CT staging, and so it's always difficult, particularly in Hodgkin, to escalate therapy on the strength of that alone.
Yeah. Look, we've taken a really invasive approach in that if we do find additional lesions, we'd like to biopsy and confirm that we've upstaged. So, you know, that's one of the things where it's my particular interest in that I do both radiology and nuclear medicine. I do interventional procedures as well. I like to get hands-on and involved in that sense. And a lot of the cases that we've had, I get asked to do it, and that's I think been our local approach for it.
So can I help you a bit on that? Why put the patient through?
Not necessarily for a bone marrow biopsy. We know that the evidence suggests not to, but if we do find, let's say, a lymph node that's small with uptake down in the groin, whereas there was only a potentially stage 1 disease with a very avid neck node, the risks associated with such a procedure wouldn't be so high, but it does make a huge difference in terms of management and prognosis.
In relation to that, I had the opportunity recently to ask the German people, Engert and Borgman, how they saw all this, and they sort of said, well, that's life, you know, that's the stage. It's based on PET now rather than CT, despite all their 20 years of data, and they seem to be happy to upstage people by PET, change treatment, but without, I was quite surprised, without knowing that it was all based on CTs.
I think you're usually lucky with the upstaging because usually if you're going from a stage 2 to a 3, you're going to find more than one side of disease below the diaphragm. So it's not just one tiny celiac node. I would think that alone would get you from AVBVD to BCOP escalated. They're probably lucky in that they have multiple sites on the PET. So yes, it's real life, and it probably is the reason why a lot of those patients may have failed in the first place. But maybe it's in the individual patient, it's not so difficult.
Another question was about the SUVs with contrast enhanced CT. There was a throwaway comment at Lugano that the SUVs were altered by the contrast induced CT, and if you did it as part of your initial stage,
so
it may make subsequent.
There are other issues with that as well. I mean, they do report about a 10 to 15% change in SUVs based on contrast, enhancement of organs, and also vascular enhancement. So. Several European and I think American guidelines suggest that you do the CT as part of the study, but you still do a low-dose non-contrast CT for the attenuation correction purposes so that you don't affect the SUV uptake. And that, I think that's the ideal way. Also because, you can't get an ideal contrast-enhanced diagnostic CT by getting it perfectly matched to the PET. Because of breathing and other factors. You want to optimise the CT and then optimise the PET CT.
Dennis, thanks very much.